Session it is going to be today because everybody nowadays suffers joint pain, especially knee pain.
I have more knee pain, joint pain.
Good. So it will be very wonderful to listen to Dr. Praveen.
We'll start the session. Okay. Good afternoon, one and all. Welcome you all to Vayomanasa Sanjeevani's webinar series. Today's topic for the day is bones and joints in older adults. To talk about this, we have Dr. Praveen Basavagowder, and our moderator for the day is Shakuntala Nagendra. I would like to welcome all the participants for today's session, all the Zoom as well as YouTube participants, and our resource person and the moderator for the day. Like you all know, our moderator for the day is Shakuntala Nagendra. She is a lay counselor, and she is also a volunteer of Vayomanasa Sanjeevani. I welcome you, ma'am, to address our speaker for the day. On to you, madam. Thank you.
Yeah, thank you, Gina. Thanks a lot. Good afternoon, everyone. On behalf of Vayomanasa Sanjeevani, a warm welcome to all to the webinar, Bones and Joints in Older Adults. This is a virtual interactive session with Dr. Praveen Basavagowder. It is a privilege to introduce Dr. Praveen Basavagowder. He has done his MS Ortho from PGI Chandigarh, DNB in Ortho, then MNAMS and MRCS from Edinburgh, UK, FAO from Swiss. He has done his fellowship in joint replacement surgery from UK, AO fellowship, that's spine and trauma and sports surgery from Austria. Dr. Praveen Basavagowder is a double postgraduate in orthopedics from the prestigious Premier Institute, PGIMER, Chandigarh, and member of Royal College of Surgeons, Edinburgh. He is a senior consultant, joint replacement, spine and trauma reconstructive surgeon with in Sagar Hospital, and also a visiting consultant at Apollo and Manipal Hospital, Jayanagar, Bangalore. His area of surgical expertise is in the field of knee replacement surgery, conventional and computer navigated, and hip replacement surgery. It's a complex primary and revision hip replacement. He also performs arthroscopic knee surgery, lumbar disc surgery, and spinal fracture fixations. He is an author of 14 international peer-reviewed scientific publications, including 7 peer-reviewed publications in the field of knee replacement surgery. Dr. Praveen's original scientific articles on the correction of complex knee deformities have been published in the Journal of Bone and Joint Surgery, both in American and British, the Knee Journal of Arthroplasty. He has presented his research in various international computer-aided knee surgery conferences in UK, France, Hong Kong, as well as at CCOT Prague. 2011 podium presentation in knee balancing session, which included Dr. Chittaranjan Ranawat as one of the speakers in this session. So welcome to our resource person, Dr. Praveen Basavagowder. Over to you, sir.
Thank you very much for a very kind introduction. So today I am going to, the topic that has been given to me, joint disorders in older adults. I would thank the Vayomanasa Sanjeevani webinar series, the NIMHANS Geriatric Outreach Clinic at the onset for asking me to address the participants. So I'm just going to, can you see my, is it possible for you to see my?
No, sir, you may share right now, sir. Just now I have made you as the co-host.
Okay.
You can share the screen.
Okay, just one moment.
Yes, sir. We can see your screen.
You can see my screen. Yeah.
Yes.
Just one moment, please.
Sure. Sir, I think now, yes. Okay.
Yeah.
Perfect. We can see the screen, sir.
Okay. Good afternoon, everybody. So I am Dr. Praveen Basanagaudar, Senior Consultant Orthopedic Surgeon. Basically, you have already introduced me. So this is the place where I did my training in Chandigarh and Glasgow and Austria. I'm basically a hip and knee replacement surgeon. And I have my clinic in JP Nagar 7th phase, where I practice. And then I'm affiliated with Sagar Hospitals, Apollo and Manipal Hospitals in Jayanagar. So one of the more, as an orthopedic surgeon, so we are called as orthopedics because at the beginning of the last century, ortho means correction and making it straight, and peds means pediatrics, children. So the deformed children used to be made straight by the orthopedic surgeons. Now slowly all those vitamin D deficiency disorders and all have all but gone currently, and now we have the role of the orthopedic surgeon is basically now to address the problems of the geriatric age. That is basically fractures or arthritis happening in the elderly people. So as you can see in this X-ray here, you can see this patient who has had both hip surgeries. As a lady for the knee replacement, there's a hip replacement, and the bottom you can see somebody who has had a spinal surgery as well as a hip surgery. The reason for this is people are living longer, and people wish to remain active throughout their life, and but there are other burning issues in this orthogeriatric. These issues are like insecurity and fear, depression, isolation, loneliness, financial issues, medical problems, other medical problems, dementia, mobility problems. And I mean, for them to conquer the orthopedic problems along with these can be quite a task. And hence, our duty is to get them to climb them up this success ladder from where they say, I can't, I don't know how to do this, I wish I could do this, to a stage where we can get them to say, yes, I did it. Now, the common reason why people come to us is because of chronic pain. And this chronic pain can cause a number of problems affecting their quality of life, as well as social consequences, marital as well as social isolation, psychological issues, and socio-economic issues as well. So the two burning issues are in orthogeriatric age group are osteoarthritis, which involves the joints, and osteoporosis, which you can see on your right. That osteoporosis affects the bone quality, and osteoarthritis affects the joints. Now let's consider the osteoporosis and fragility-related fractures. So in osteoporosis is a condition where the bone quality becomes poor, the bones become thin and weak and brittle, and often there are no warning signs before a break occurs. So you can see the good quality spinal bone, that's a vertebra, on your left side, and then you can see a vertebral fracture. You can see the hollowness in the bone in the case of osteoporosis. What are the symptoms of osteoporosis? The osteoporosis is mainly a silent disease. The patient do not have any problems unless suddenly they have a fracture. And you know what happens when a fracture happens. It's pain and disability and loss of function at the appropriate place, whether it is the hip, the wrist, the ankle, the spine. Okay. But before a patient presents with fractures, some of them can have what we call as generalized body aches and pains, and have backache. So who develops osteoporosis? It's quite common in elderly women, men and women both, but more so in post-menopausal women. Smokers and alcoholics tend to have more of osteoporosis. People who stay indoors, who have a sedentary lifestyle, lack of sunlight exposure. And currently in the COVID scenario, most of the people who are staying indoors can develop osteoporosis because the walking is reduced and a lack of sunlight exposure. So how do you diagnose osteoporosis? I mean, when the patient presents with a fracture, obviously the X-ray will show a fracture and you can see the quality of the bone on the X-ray. But for diagnosis before a fracture happens, quite commonly, many of you might have attended bone density measurement camps where they place your heel in an ultrasound machine and then they check using ultrasound waves. Here there is no radiation and this is a common screening test. Although this is a common screening test for the population, the DEXA is a very more accurate and specific test, and although it uses radiation and it can be expensive. How do we treat osteoporosis? The best way to treat osteoporosis is to prevent osteoporosis by building healthy bones. Of course, I am not going to go much into details of the treatment. Other than that, patients can take calcium and vitamin D supplements. Other things you need to see your doctor for established osteoporosis treatment. But how to build healthy bone? Well, regular weight-bearing exercises like walking, climbing stairs, jogging, cycling, exposure to sunlight, avoiding alcohol and smoking, a diet rich in calcium like milk, ragi, pulses, cereals, green leafy vegetables, fruits, and also start building healthy bones from a very young age itself. So by boosting the calcium intake as well as regular weight-bearing exercises. Very important that when children, do not stop them from running around, because quite commonly we say, oh, don't run around like monkeys. I mean, whether it is humans or any other animals, you can see that they develop their resilient, good bones in their childhood when they run around. So prevention is better than the cure. But what do we do when patients have a fracture? So hip fractures, there is a saying in our orthopedic book that man comes in the world through the pelvis and goes out through the hip fracture. Not the hip fracture which kills, but the medical conditions associated, the dehydration, pneumonia, bedridden complications and all. So people can have chest infections, clot in the leg going to the lung, heart attacks, strokes, things like that. And to avoid all these complications, hip fractures in the UK, they are fast-tracked. Fast-track means within 24 to 48 hours, the procedure is done for them, bypassing all other this. So if a patient presents with a fracture, like as you can see on the top left, so this is an extra-articular hip fracture, extracapsular. We reduce the fracture, fix it, and move get the patient to move. And for another type of fracture, we excise the ball and put an implant like called as a half hip replacement and get them to move. But the bottom line in hip replacement is whether it is a nail or a plate or an implant prosthesis, we get them to move because walking is the passport to life. This is an example of wrist fractures. So you can see them, they have been treated in a plaster and occasionally they require some minor surgery like wires or plates. The important facts of osteoporosis is 67% of our people do not realize that there are steps they can take to improve their bone health. And only 35% of the people recognize that physical inactivity increases the risk of osteoporosis. Out of people, 100 people who are underweight, only 20 of them know that being underweight will put them at a greater risk of osteoporosis. 80% of them are ignorant that their underweight status will cause early risk of fractures. So, I mean, 70% of the people under the age of 30 years do not know when they will have to start making the lifestyle changes they need to ensure strong bones. Important thing here is in osteoporosis starts after 40s, but the bone growth, the quality of the bone improvement can happen up to 35 years. So, I mean, up to the age of 35 years, if you have obtained what we call as a peak bone mass, then after that, every year, part of the weight will, bone weight will start getting reduced either by 0.5%, 1% or 2%. But if it reduces 0.5%, that means you are taking all the precautions like exposure to sunlight, walking, active lifestyle, good nutrition. The attrition of the bones is less. So you are automatically protecting yourself against fractures. But if the rate of loss of the bone is more, you can end up with the fragility fractures within a decade or two. So if it started at 40, people can end up with fractures by 60. So they need to be aware of these lifestyle changes that they need to make at a young age itself. And it's important here that the senior people do pass on the message to the people at their home, including their children and the grandchildren. So because bone quality improvement starts at a very young age. Now, going to the other important condition, osteoarthritis. So this is an example of the knee. This is a picture of the knee. You can see that here the cartilage is good and here the cartilage is all worn out. So this is how on the left side you see this white one, that's the good cartilage, and the red one, this is all worn out cartilage. Now this in our country, no, generally in the world over, the 5 to 6% of people around the world have joint or joint related diseases. And the commonest is osteoarthritis. And even in people from 40 to 60 years, the incidence of osteoarthritis is 60%. And as the age increases beyond 65 years, the incidence of osteoarthritis is as high as 70 to 75%. And osteoarthritis not only involves the knee, commonly it involves the spine, what we call as spondylosis. Lumbar spondylosis is the low back. And neck, if it involves, it's called a cervical spondylosis. The incidence of hip arthritis in our country, luckily, is less. So basically, it is a cartilage disease with a bony reaction and inflammation of the soft tissues around the joint, and it leads to disabling pain, restricted motion, and function. It's the second most common disabling disease after ischemic heart disease, means heart problems. That's those who have a heart attack or those who have had a stent or bypass. These are all the ischemic heart diseases. So osteoarthritis is more common in women. And so there are so many changes that happen in the joint itself and also in the bones. And this is an X-ray which shows the reduced space which is seen in the joints. So also back is a very important structure of a body. Why I'm just considering this one at the same time is that there are other problems like lumbar disc, canal stenosis, which happen because of the osteoarthritis of the back. So symptoms and signs in the knee or the hip or other joints also. So the osteoarthritis basically involves the knee joint, sometimes the hip, quite commonly the back and the neck, and also the small joints of the hand. Technically, it can affect any joint in the body. So in the knee, it presents as pain, swelling, and deformity with restricted motion. These are the things what we find intraoperatively. So osteoarthritis, we have to know what are the modifiable and non-modifiable causes. So age is something which we can't modify. And even the sex, the women are more prone to osteoarthritis. That we can't change. Hereditary causes, you can see like in some families, arthritis runs in families. They have bow legs or knock knees. And if you interrogate, you will find one or the other parents having osteoarthritis in their family. Now, so when you can't modify these, let us talk about what we can modify. Modifiable causes are being overweight, which is very common nowadays. Okay, I think mainly due to the dietary issues as well as the sedentary lifestyle that we all lead. Lack of exercise, yeah. And I mean, in this COVID pandemic, a lot of people have gained weight just because of not going outside and also not being able to control their eating. Repetitive joint strains, joint injuries, these can be avoided. Diabetes is another cause of pain in the knee, and so is metabolic syndrome. So metabolic syndrome where people can have diabetes, hypertension, gout, obesity, all these things. And obesity itself is a thing which can affect the back as well as the hips and the knees. So obesity usually doesn't affect the small joints of the hand. So a happy orthogeriatric patient, if you see, for me being a joint replacement surgeon, I usually end up correcting their deformities and making these people walk, those who present to me with a very severe arthritis. But the vast majority of the patients, 90% of them, do not want any surgery, do not want any implants, and they would want to do without any surgery. So a lot of these would come to the doctor and say, give me medicines, doctor. Okay, and they are happy eating medicines, whether the medicines work or work temporarily or only up to a particular time. And a lot of these people are not motivated to do exercises. And so should we be prescribing diet and exercise? Well, obviously, yes, for osteoarthritis. It is never too late to do a diet and exercise, but it can become a challenge getting the people in senior citizen to do diet. Okay, because dieting too much can cause nutritional problems for them because of malabsorption issues and all. And getting them to exercise may be a challenge because they already have knee arthritis. So also, if we look at the public attitudes, people do not want medicine and they don't want to make the lifestyle changes also. So this can really become a challenge. So it is important to make the lifestyle changes to get the desired result. And severe osteoarthritis patients, another challenge, those who really require knee replacement, they don't want to do the surgery. They just want, a lot of people are there who keep on eating some painkillers, and they eat the painkillers, and a lot of them develop renal failure, kidney problems. So it's very important to make judicious use of these medications. So the multidisciplinary pain management team, you can see it is an integrated, coordinated, and interdisciplinary team consisting of the primary clinician, mainly for us orthopedics surgeon, but we also need the help of different subspecialties like pain specialists, psychiatrists, neurologists, psychologists, occupational therapists, physiotherapists, anesthesiologists, social workers, pharmacists, spinal surgeon, and the nurses, physical assistants. So approach to treatment of arthritis is diagnose the condition. You need to see your doctor. Treat the underlying condition. Okay, there might be more than one underlying conditions. So the best thing is to prevent them. We already talked about that. Once you have got pain, how do you reduce the pain? Improve the physical function and reduce the psychological distress that the patient is having, and the improvement in the quality of life by treating the underlying condition. So generally, this is a Wong-Baker scale, which says if you have to show your pain on a scale of 0 to 10, where 10 hurts worst and 0 means no hurt. So 2 to 3 is considered as mild pain, and 4 to 6 is considered moderate pain, and 7 to 10 is the severe pain. And usually it is the 7, 8, and 9 or 10 pain who usually end up coming for surgery, especially if this pain lasts for a long time. So treatment of the pain is a continuum. We use the least invasive method first and go to the last most invasive method at the end. So for example, the osteoarthritis is knee. It's the treatment of this should be like multidisciplinary, where you start with exercise and lifestyle, then go to the over-the-counter medications, then prescription medications by my doctor, and then injections, and finally the surgery. So as you know, this arthritis is a imbalance between the degradation of the cartilage and the synthesis of the good cartilage. And these are the different stages. I don't want to go into the details of this. Treatment goals are mainly to relieve the pain, improve the muscle strength and conditioning, preserve independence and mobility and quality of life, and minimize the complications of therapy. And these are the European League guidelines. Treatment should be tailored to each patient. So you can't generalize and tell one patient, one treatment fits everybody. So it's a two-way health relationship between the healthcare team and the patient. Patient education has a significant impact on the pain management. So once they know more about their disease, whether it's going to improve or going to stay the same, what are the things they need to do, and also based on this, the patient, once they get educated, they participate in the treatment of their arthritis. They tend to have better results than those who don't participate in the treatment. So treatment can be non-pharmacological, like exercise and all, pharmacological with medications, and then surgery. So you always see that surgery is at the apex of the pyramid, and only a few people require that. But the vast majority require education, physical and occupational therapy, weight reduction, exercise, and assistive devices. For mild to moderate pain, paracetamol or ointments. For severe pain, they might require some painkillers. And some people where these things, the bottom ones are not working, they might require injection into their knee, either by steroid or viscosupplement or the platelet-rich plasma. And when things don't work, despite all this, one might require surgery. But topical analgesics or ointments or liniments can be used throughout. So we have already discussed about this. So patient education, lifestyle changes, weight reduction, diet changes, joint preservation techniques. So try to avoid unnecessarily overuse of your joints. If you know you're having knee problem, avoid running. Maybe you can, if the knees are designed for walking, so continue walking. Don't stop that. Yeah. Occupational. So osteoarthritis lifestyle modification. I mean, a lot of thing is avoiding bad things and doing the right things. So vegetarian food is very important in the fight against osteoarthritis, because the vegetables do contain certain glucosamine supplements naturally, which is helpful for cartilage regeneration. Also, when you try to digest vegetables, they are 0 calories. So when you try to digest the vegetables, your body tends to spend energy trying to digest something which doesn't have calories. So the body ends up losing some calories in trying to digest the vegetables. So that's good. So metabolic syndrome, I have gone through this already. I mean, you avoid overweight. Okay, so this is a low physical activity, problems related to eating, stress, or sleep, and all. So these people usually can have obesity, hypertension, diabetes, gout, cholesterol problem, thyroid, polycystic ovary disease, low backache, arthritis. Tertiary problems are in these patients, if they have it for many years, they can end up with cardiac problems, heart problems, kidney problems, stroke, and vascular problems. So physical therapy and exercise is very important. Even in those people who are healthy, it's better to do some physical activity. It promotes better health. Lack of activity is also linked to depression. So move, and then the chances of depression, asthma, colonic cancer, heart problems, stroke, all of them reduces. And depression is also associated strongly with the chronic pain. So if you move, it causes less depression, and less depression is associated with less pain. So reduced physical activity can worsen the chronic low backache or even the knee. So this is me. I mean, I have lost about 15 kilos, and I do a lot of running and all those things. And that was me before, many years before. With a sedentary lifestyle, it can happen to anybody, but I mean, it is important to understand, realize that, and put the practical steps in place to try to reduce the weight. And then we have to lead by example. We have to do it ourselves so that the people in our family can also follow. Physical and occupational therapy, there are a lot of exercises. These are some exercises. I know I don't want to go into the details of this, but you need to do exercises for the back, the legs, standing exercises, okay, stretching exercises you need to do for the knee and the hip also. So other things like stationary biking, swimming, floor exercises, black flattening means lying on the firm or a hard bed, that is black flattening. So these are some important stretches for the people nowadays who use the computers as well. So exercises, yogasana is yogasana. These are the floor exercises. Generally, people have to move. So 30 minutes of physical exercise for at least 5 days a week is good. If you can't do 30 minutes at a stretch, you can do 2 15-minute stretches. Once in the morning and once in the evening. And actually you can slowly start up with the 5 to 10 minutes and then gradually build it up to 15 minutes and then finally to 30 minutes. Important to realize that no need of vigorous exercise, but what we need to know is we need to do 5 days a week. And if you can't do 5 days a week, there's a concept as many times in those people who don't get anything then they are called as the weekend warriors. At least get that 150 minutes of exercise for the week in over 2 days, Saturday and Sunday, like that. So any activity is better than no activity. And so people who use the lift to walk up and instead and just put on their TV rather than using the remote, small things. I mean, never too late to start, and it is best to select the enjoyable activities. What you enjoy most, you do that for physical activity. And I just put this because nowadays a lot of senior citizens are also on the computers, and there are a number of things which can happen because of the computer related issue. So, I mean, it is important to sit straight. Sorry. There are the different things that we need to keep in mind at the wrist and the elbow, the neck, as well as our seated posture. So, prescription for physical therapist, posture training, deep heat, cold heat treatment, massage, acupuncture, hydrotherapy. So many things are there. This is usually recommended by your physiotherapist. For the knee, hot fermentations. So this is a hot fermentation and cryo cuffs, the cold cuffs. They help. Knee splints or knee braces. Also, this SOR is the strength of recommendation. Okay, so local gels, pain relieving liniments, cane or walking stick or a crutch can reduce the pain by 30%. And there are people can use insoles. You can see this patient who's had a knee replacement. This is the hinge knee brace which we are using on the right side. So pain medications can be simple things like paracetamol at home, but if you need painkillers, you have to speak to your doctor. So other things are like if you see the patients, only 10 to 15% require knee replacement. What about the 80 to 85%? So if they can, only 20% are satisfied with their current treatment, because this osteoarthritis is a gradually progressive thing. Even if we did everything to stop it, it's like a tires of a car. The more you run the car, the more the tires get worn out. So, I mean, it's important to run your car well. You have to keep it in motion, but equally you have to run it over good roads and avoid the bad roads, and you use the car smoothly. Like that same thing with the knees. And despite doing all the things correctly, still the wear out happens. So it can take about 10 to 20 years before the patients become the subjects for knee replacement. So about 60% don't know what to do, waiting the patient gap, we call it as waiting out the pain from 2 to 3 years to 15 to 20 years. They don't know what to do. So they're ready to try anything before getting the surgery done. So this is a simple outpatient procedure which can be done. Like the abnormal joint fluid is sucked out, and in its process, you inject it with a gel which goes and fills up. This is the thing which you can see on the right side, the blue thing. You can inject a platelet-rich plasma to try to get the cartilage to heal. Still, a lot of research needs to be done in this direction. Steroids are used only usually after the age of 60, 65 years, and they help for good pain relief, but they don't stop the cartilage degeneration. It can progress. And so physiotherapy is very important. And for surgery, I mean, there are smaller procedures like arthroscopy keyhole surgery, which can be done when the small meniscus, like this in between. The meniscus is the tissue between the bones. And if it is torn and getting stuck in the knee, you can do these small procedures. There are other things like the malaligned knee can be corrected by outside the knee joint by doing osteotomies. So you can see these things fixed with the staples and the plates. These have been correction of the deformities. And if it is badly worn out, you replace the knee. So for a knee replacement, you need a good patient with a proper severe pain, a lot of deformities, and they need to meet the right surgeon, and you have the right selection of implants to have a good result. So the right candidate for total knee replacement is the one who has got severe knee pain with functional impairments in the activities of daily living, and they can have a deformed or unstable painful knee, and sometimes a severe knee arthritis with a stress fracture as well. So this is the one of the examples of one of my patients about 10-15 years ago. So this lady underwent both the knee replacements. She is alone. She had the first surgery at 75 and second surgery at 78. Now she is 84. She walks. I mean, it is amazing. At the age of 8 years, she went to Vaishno Devi and climbed 2,000 steps there and called from there. They take that well. I have done this. I mean, you never know who can. Quite a lot of them. Once they overcome their problem, I mean, if the spirit is good, they can literally achieve anything. So. And good news is this physiotherapy and all that can be done for the hip also. Thank you very much. Hello.
Thank you, sir. Can you please take some questions from?
Yeah.
Dr. Praveen, good afternoon,
Yes.
sir.
Good afternoon. Good afternoon.
This is Dr. Mahesh from Abu, Rajasthan.
Yes.
Sir, we have a patient who has undergone hip replacement surgery at
Okay.
Ahmedabad. At
Okay.
Ahmedabad.
Okay.
Patient recovered well, but the swelling is there, pain is there. And the surgeon assures that by giving serratia peptidase, chimeral report, it will subside. And he has advised exercise, mobility exercises, finger movement exercises. Like any other thing you'd like to ask in this patient, like how?
Well, the swelling, where is the swelling? Is in the hip or in the foot?
In the thigh, little bit thigh and legs.
Okay. See, a little bit of swelling in the thigh and leg after the surgery is well known. Okay, it can
up to 1 month. Up to 1 month it will be there.
Yes, up to 1 month it can be there. Yeah, a little bit more than the opposite side is fine. But if the swelling is more, you have to rule out two things.
DVT.
If there is swelling around the hip region, rule out any infection, okay, or any delay in the healing. If that is not there, the other thing that needs to be excluded is the clot in the leg. So you can get a venous Doppler of the lower limb.
And they have actually, surgeon has given low molecular weight heparin during.
That's fine. Yeah, no. Despite that, if you feel the swelling is more than normal, you can get a venous Doppler of the lower limb. And if the venous Doppler rules out a DVT, so then you can actually then you can say that the swelling is probably not related to any clot, nothing major. And then you can advise them stockinets, limb elevation, crepe, and movement itself.
Movement.
Swelling comes down. Yeah.
Next
6 weeks to 3 months. Yeah.
Actually, the surgery is over 8 days back.
No, that's too early. Too early days. Just follow your surgeon.
Okay. Matlab, there is no need to do Doppler now, na?
No, you just speak to your surgeon because it is difficult for us to assess. But I've just given you a.
Actually, I shared this idea with the surgeon. He said we have given low molecular heparin, nothing to worry. So if it come down, he said.
Yeah, if it came down, don't do anything. If it got worse, get the venous Doppler.
But patient moves with walker. He has been advised to move with walker.
Fair enough.
Surgeon has advised patient to move with the walker and movements he has allowed.
Yeah, I mean, I think you should follow your surgeon's advice.
And second thing is treating elderly osteoporosis after 75 is really challenging because calcium does not work.
Yes.
Those patients who cannot tolerate anti-resorptives, how do you treat osteoporosis after 75? See,
I mean, osteoporosis, it's like a cafeteria approach. I mean, calcium doesn't get absorbed. I mean, as I told you, the treatment for osteoporosis is prevention.
Okay, that is okay. Okay, but you keep before 75, you keep on treating with calcium, vitamin D. You can
treat them with calcium, vitamin D. You can use this bisphosphonates if they are really bad. You can use the bisphosphonates. You can use the zoledronic acid injections once yearly, or you can use the once monthly tablets. You also have got these alendronate formulations in the form of jellies. So you can use to avoid the acidity and all associated with them. Then you have teriparatide injections for the severe osteoporosis. You can also use certain things like decaderbalin and all for people who are having sarcopenia. So muscle, the weak muscles, or if you want to have an anabolic effect, you can use those. Then there are so many other, the calcitonin used to be used, but I think current guidelines you don't use it for more than 6 months.
Spray.
Yeah, you can use the calcitonin spray as well. Then you can combine these and just, there are so many things available. I mean, the commonest things are calcium, vitamin D, and vitamin B12, folic acid, all these things. In addition to that, you use bisphosphonates. But more beyond this, you usually get a dexascandan. It's confirmed.
After 75.
No, yeah. I mean, if sometimes after 75, we think there is osteoporosis, maybe they may not be having osteoporosis. You have to see the T score and the Z score. And if the scores, so you compare it with a 20-year-old, but at 75, you don't compare with a 20-year-old. You have to compare 75 with a 75. So if it is above that graph, that you see the curve which they show, as if the bone density is above that curve, so then usually for their age it is appropriate. I wouldn't rush to treat reverse osteoporosis, which is a very challenging thing to do. But if patient doesn't have any body aches, they are asymptomatic, I would give them the calcium and vitamin D. But if they are high risk of fractures, or they have had multiple fractures, in which case I would start them with calcium, vitamin D, then bisphosphonates. I would add teriparatide if they have any delayed union or a non-union, or if they have got severe bony symptoms.
And teriparatide, at what BMD you start?
No, it's not like, I mean, as I told you, I think I am not over treating osteoporosis.
BMD 3?
Yeah, but -3, -3.5, -4, these are, but I mean, I would discuss all these things. I would see each patient's, hello?
Yes, listening, sir, listening.
Yeah, I mean, I would see what is the response symptomatically by starting the simple things first. Okay. And despite these, and I would always warn the patient that despite your best effort, you still have a risk of fractures up to 50%. So you can reverse the osteoporotic things. You can improve the bone density, but you can reduce the fracture risk by only about half, despite your best treatment. So, I mean, in the remaining, maybe you are trying to avoid a comminuted fracture, or the quality of the bone might be better when they fracture, but you can only reduce the fractures in about 50% of the cases, not more than that.
Thank you, sir. Thank you.
Yeah.
So,
Thank you.
Keshav, sir, you can unmute and ask your question, sir. Keshav Bhatt.
Please unmute your mic, no?
Hello?
Sir, your mic is on mute. Keshav Krishna, sir? Okay, I think Jambunathan sir have raised his hand. You might go ahead, sir.
Doctor, good evening.
Good evening.
So thanks for the excellent session on this. See, does it include this rheumatoid arthritis, doctor? Rheumatoid arthritis? Yes. I mean, your specialization, does it include rheumatoid arthritis?
No. I haven't included rheumatoid arthritis as a part of this discussion because I was given the topic of bone and joint diseases in the elderly. Yeah, I mean, rheumatoid arthritis can affect at any age. It can affect in children, it can affect in young adults, older adults, middle age, as well as old age. Rheumatoid arthritis is different from the osteoarthritis. This is the degenerative. What we discussed is the wear and tear, which happens with age and progresses with age. But rheumatoid arthritis can affect at any age, and it comes under the classification of inflammatory joint diseases. These are associated with more crippling arthritis, more swelling, more destruction of the joints, and they can affect any ages.
So it's not
similar.
So it's not indicated only in old age. It is indicated in any age.
What?
This rheumatoid arthritis.
It can happen at any age. It can happen in children also.
I see. Okay, Dr. Raman, what is the basic treatment, or what is the basic, how do you determine whether it is rheumatoid arthritis or not? Any common guidelines, doctor?
See, the rheumatoid arthritis patient doesn't come with only one joint swelling. They come with multiple joint swelling. Okay, they have deformities. Okay, so they have swelling, warmth, hot joints. Okay, they can't move their joints. Rheumatoid usually affects the small joints of the hands and the feet. It can also affect the knees, the elbows, and all, but mainly hand joints, wrist joints, and it is there in both the joints. They are associated with morning stiffness for more than 1 hour, and they can have other features like raised ESR, CRP in them, and they present with deformities, and they can present with. And nowadays we are seeing this sort of inflammatory joint disease. Some of them post-COVID scenario, also post-chikungunya. Okay, so these are called as inflammatory joint disease. Okay, so they are different from osteoarthritis.
Thank you, doctor. Thank you. Thanks for.
This is Dr. Asha Vijay Rao from Pune.
Yes, good evening, ma'am.
I am a geriatric care worker, and I would like to know the cartilage of the knee, especially as you have shown. Once it is broken, it does not regrow in any case.
What? The cartilage?
Yes, sir.
Cartilage?
Yes,
cartilage.
Sir.
Yeah, yeah. So like all other, is that the end of your question or you want to continue? Yeah. Hello?
Hello.
Can you hear me?
Yes, sir. Yes, sir.
Is that your question? Yeah, that's it?
Yeah. Cartilage.
Yeah. The cartilage, see, like most things in life, if you have a fracture in a child, and even if there is a deformity, the body has got a tendency to correct that deformity naturally.
Correct, sir.
The younger the child, the better the solution to that, natural solution to the thing done by the body. But as age happens, the fracture healing reduces. And towards as people become more older, the chances of healing reduces. Similarly, the cartilage also, if the cartilage is permanently lost, well, then it cannot get replaced. But if cartilage is partly damaged, the chances of the best healing takes place in children and in young adults. And as age advances, the chances of cartilage regeneration becomes lesser. So body always tries to make sure that it repairs its own tissues. Okay, so if the breakdown of the tissue is more than the forming the tissue, then obviously it's like mathematics. If you lose 20 and gain 30, so there is a plus 10. But if you lose 30 and gain 20, it is minus 10. So if that continues for a long time, then you lose cartilage. So with age, with advancing age, the cartilage wear becomes more. And the wear of the cartilage is also determined by other things like deformity of the bone. Some people have bow legs, knock legs, and as the bow legs leads to cartilage wear, and cartilage wear leads to more bow legs, and more bow legs leads to more cartilage wear. So it's a vicious cycle. So there are so many things that we need to keep in mind when trying to treat the
patient
cartilage problems.
Sir, you have been doing a lot of research work during your research work. Have you ever thought of giving a thought to cartilage replacement also, if any way there is any thought of it?
Yeah, see, the thing is, a lot of research is happening currently. Let me tell you, when I started about 25 years ago in orthopedics, at that time we had a talk in Jaipur in 2000 year by Dr. Chitranjan Ranawat. He did the knee replacement on the late Prime Minister Vajpayee ji, and he gave a talk about what is the role of knee replacement 20 years from now. And he told, after 20 years from now, the knee replacement will be there. It will not go.
Correct.
Okay. So, but the focus throughout the world has been there to try to find alternatives to knee replacement from the long time. Okay, so physicians are trying to find out medications to prevent. There are lots of people who are trying to do cartilage growing, and then you are using bone marrow aspiration, you have rich plasma and all. So I mean, you are trying to use many things to try to reduce the progress or halt the progress. If you are able to halt the progress of arthritis, then that's like a cure. But if you reduce the progress, then you can buy more number of years. So this sort of cartilage, lot of work is happening currently. Maybe in the future, I mean, that might be there. But I mean, but these are words said by Dr. Ranawat in 2000, and this is 2021. And what he told was correct. So how can we try to correct the bone deformity with medicine?
Correct.
So that can be a challenge. So while you can try to improve the cartilage in the knee joint, what about the bow knees, bow legs? Okay, knock knees. So these require mechanical correction. So there are lots of things like inserts and all which are being used already to try to improve this. But have they led to a cure? They have been in use for last 15, 20, 50 odd years. Okay, have they really got a cure for that? No. They help 15%, 20%, whatever. Like, and you use a lot of these things like a cane, a good shoe, you use insoles, you use kneecaps. All of them help little at a time, but none of them in solely have been able to give a cure. Even knee replacement helps only for people with very end stage osteoarthritis, those who are really struggling to walk few steps, or they can't do half a kilometer, or they have severe deformity, getting difficulty in doing the activities of daily living. Yeah, work, yes, it is happening around the world, and I hope to see it during my lifetime.
Thank you, sir. And it was wonderful hearing you. Thank you very much.
Thank you very much.
On Mr. Rashmi J. Bhatt, she has a question. Is there a specific regimen of calcium intake for post-menopausal women? And also my question too, sir. Sir, what may be the duration of the intake of calcium tablet? And on the shelf, we are getting tablets with vitamin D as a supplement, along with calcium vitamin D. Is it okay to take those tablets, and what is the duration like wherein we can continue taking them?
Okay. So, I mean, let's start with the calcium. So, is it good to take? I mean, lots of people discuss a lot of things. If you ask me in person, do I take? Yes, I do take. I mean, I do run. I run up to 40, 50 kilometers at a stretch also sometimes. But do I take calcium? Yes, I do. Do I take regularly? Probably not. But I do try to take 3 days a week at least. So, I mean, see, there are different regimens. You can take continuously if you are established osteoporosis. If you are not established osteoporosis, but you want to look after your bone health, you can. Basic thing is you need to have 1500 milligrams of calcium per day. So whether you take it through milk, paneer, non-veg, or curd products or whatever, or whether you want to take tablets. So tablets is only to supplement that what you are not taking in diet. Calcium will help to. So if you have taken only 1000 in your diet and you need 1500, one tablet of 500 milligrams calcium will help that to make it 1500. Okay, body is very intelligent. It will absorb if it wants. If you give it 2000, it may not absorb if you are taking adequately. But if you are not taking, then it will absorb. So the role of calcium is basically when your body has a deficiency and you don't know. For example, when your petrol goes off, you get a warning. You see that. But in the body, there may not be any warning that you are not taking calcium on a daily basis. So if your intake of calcium is low, you can take calcium supplements. You can take 1 tablet or 2 tablets. So, I mean, the thing is, if you take a good diet, I mean, maybe 1 tablet a day, That's fine for, especially for postmenopausal women and those who are at higher risk for osteoporosis. Vitamin D, yes, 60,000 international units of vitamin D per month. Even in people whose vitamin D is normal, up to 60,000 international unit per month, that equates to 2,000 international unit of vitamin D per day is the appropriate dose which is required. But generally, most of the tablets that you take will have 250 or 500 international units of vitamin D. But yes, vitamin D also you can take. There are other multivitamins like vitamin B12, vitamin folic acid, which you take in multivitamins. These are also useful for the bones. And vitamin C is very useful for the soft tissues, the ligaments. So I mean, people take it continuously for, say, there are certain regimens where people take it for 2 months on, the 2.5 months on, they take 15 days, they stop, and then again they repeat the cycle, 2.5 months on, and then 15 days. So that's one of the ways of doing. Some people take every alternate day, but I mean, taking some calcium is better than not taking, and there is no role of overtaking calcium. And I mean, you won't know how, if I took this much, how much am I protected? No, your body is intelligent. If you think you are not taking sufficient dietarily, then if you took a calcium, body will absorb. Body will not over-absorb, but the risk of over-absorption is only 1 out of 100. Okay, so somebody by taking excessive calcium can get calcium stones in 1 out of 100, but 99 times they don't get.
Thank you, sir. Madhuri ma'am has got a question. Can you please unmute yourself and ask, ma'am? Madhuri? She has put, please suggest an effective remedy for SCIATICA, sir.
Sciatica. Well, sciatica, I think basically sciatica is a pain going into your legs. Okay. So, I mean, just share my screen. So you can see in this screen, you can see there the bone, the disc problem. So disc can press upon the nerve and cause what is called as a sciatica problem. So in sciatica, people can get pain going from the back and the back of the hip, thigh into the leg. You can see there, and the disc can bulge out here. Like you see the normal disc, this is the abnormal disc. It can irritate the nerve. So I think important thing in patients with backache, the sciatica, they can have either a disc problem, spondylosis, canal stenosis, or I mean, these are the common causes of low backache. So I mean, these patients should ideally see their orthopedic surgeon or spinal surgeon or a neurosurgeon, get their MRI done, okay, and see if there is any problem, any pressure on the spinal cord. And based on that, your specialist will help you either with medication, nerve soothing medications, and in some patients where the pain is terrible and not getting better with medications, physiotherapy, if things are not getting better, anything in the world that you are trying to do, and if MRI shows a significant compression, and some people benefit from surgery like discectomy. So basically, it is a nerve root irritation. Where if it happens in the neck, as you can see on the left, it causes pain in the arm and it is called as brachialgia. And if it happens in the leg, it's called as sciatica.
Thank you, sir. Thangarajan, sir, can you unmute yourself and ask a question? Thangarajan, sir.
Hello?
Hello.
Can't hear.
Hello. Can you hear me, sir?
Yes, I can.
See, I am Keshav Bhatt here.
Yes.
Excess of uric acid in the body affects only in the knee joint or any other parts?
Well, okay. That's a good question. So the uric acid, excess of uric acid, it is called as hyperuricemia. Okay. So all patients with high uric acid may not have joint pains. In fact, the hyperuricemia is commonly asymptomatic. It doesn't cause any problems. But in some people, the commonest joint where it causes is in the foot. Okay. So usually the big toe. It can also cause in the ankle, cause in the small joints of the hand, wrist. It can cause in the elbow and the shoulders as well. And it can very rarely cause in the back also. But the commonest one is basically in the foot.
Any good treatment for that one?
And you have to check your vitamin, your uric acid levels. If it is too high, and if you are having symptoms, so there are things which you go and see a specialist, then they will guide you regarding medication treatment. So for acute gout, sudden pain, and if uric acid is high, there are a number of medications which can be used to reduce the uric acid. But if you want to ask me regarding your borderline, little bit uric acid high only, you can follow dietary advice like lot of water to drink. Okay. Avoid meat, eggs, alcohol, sprouts, the lady finger, any vegetables with lots of seeds. So these seeds are the cause of, they have high uric acid, and the other natural things which have been used for reducing the uric acid is vitamin C fruits and black coffee, not more than 3 cups per day, and avoiding dehydration, avoiding over exercise, and avoiding soft drinks. Pardon?
Thank you, sir.
Mahesh sir, can you unmute and ask your question?
Sir, Dr. Praveen, how long we can use zoledronic acid?
See, the thing is zoledronic acid. See, previously in the UK, they used to use the bisphosphonates for up to 5 to 10 years. Okay. Now it comes with a warning not to use beyond 3 years.
Okay. And how to use alendronic gels here?
See, the gel, so the alendronic acid, the gel formulations are available. You can use them before you're taking breakfast, just like any alendronate. How you use the alendronate first thing in the morning with a glass of water, do not lie down and all those things. But because it is in a gel formulation, you eat the gel and take some water and avoid eating anything else immediately thereafter, so that
it should be consumed.
Yeah, it's a jelly. Okay.
It is not local application.
No, it is a alendronate mixed with a gel, so that it doesn't cause gastric irritation. These are
okay.
It is the same medicine. Okay.
Thank you.
Any more questions?
Dayashankar sir.
I have some questions in the chat box.
Dayashankar sir has got a question.
Yeah.
Doctor.
Yes.
Doctor, this is Deven Rekundi here.
Yes.
You talk about running in elderly.
No. I am not talking about running in elderly. There are people who are elderly who are running, and they need to be running from a long time. So I wouldn't advise anybody to start running immediately now. Okay. But if there are people who are doing running from beginning, so so if you ask Milka Singh, he was 90. So you might have been running till 70 or 80. So the running is only for people who have already been doing it earlier.
It needs assessment.
What?
Assessment for the running.
No, have you been doing it before?
No, I used to do it.
Yeah, how long ago was the last time you did it?
About 20 minutes.
Yeah, you are able to do 20 minutes. Yeah, if you are continuing what you are doing without exerting yourself too much, and if it is, you have to be aware during running that you are not overdoing things. One is to avoid injuries, and then one is to avoid the precipitation of any hidden cardiac issues and all those things. Okay, so a light jog if you are, instead of running, if you are doing jogging. Okay, and basically whether you want to do jog or brisk walk. They are almost similar. Okay. So, I mean, anything which breaks you out into a small sweat, whether it is brisk walking or a light jogging, they are good enough.
Okay.
Exercise.
So
Thank
one
you.
Mr. Dayashankar has got a question. I'm
Yes.
taking Instavel 100 mg for diabetes. I'm having joint pain of shoulders and trigger finger. Is it because of the medicine? What can I do to mitigate the pain?
Well, I mean, see, in diabetes, people have lots of high sugar in their blood, but the blood sugar is not able to enter into their muscles. Okay. So, although there is a lot of sugar flow, circulating in the blood, it is not entering the muscles. Okay. And when they doesn't enter the muscles cry out in pain. Okay. So, they can feel weak, fatigued. And there is also this element of stickiness which happens in the joints and in the soft tissues around the joints, in the muscles, ligaments, and trigger finger is one of those. So trigger finger is a trigger finger, frozen shoulder, diabetic shoulder related pain, peripheral neuritis, people having numbness or pins and needles in the foot, weakness in the shoulder and weakness around the hip region. These are all things which are related to suboptimal or poor control of diabetes. So, I mean, people have to invest time in diet, okay, and exercise, diet, exercise, and their medication. So, all these three, despite doing all the three, I mean, with time, the diabetes also can progress. Initially, only diet is enough, diet and exercise, but diet and exercise and complemented by medicine. Okay, they should be doing optimum diet, optimum exercise also. And if you have already had trigger finger and all, if your diabetes is uncontrolled, you have to wait for 2-3 months. If you control your diabetes very well from today, the results of that may be seen in a couple of months. So, I mean, you need to continue doing that. The trigger finger is more a manifestation of a diabetes than a side effect. I've never heard about a side effect causing a trigger finger following taking the diabetic medication. It is because of the diabetes. Diabetes, high sugars, sticky. You know how sugar is. When you touch sugar syrup, how it is sticky. Okay, so the same stickiness can be there in the shoulder as well as in the fingers. Okay, as well as in the joints of the small joints of the fingers. So you need to control your diabetes.
Sir, Chetan, can you ask your question, please?
Yes,
like he has put it in the this thing. Chat
Thank
box
you.
that he has a question.
So Dr. Praveen, I had my, hope I'm audible.
Yes, I am. You are. Please go ahead.
Okay. Yeah, thank you, Praveen, sir.
Yes, please go ahead.
So Dr. Praveen,
now you are not audible.
My father just went through a second surgery. So this.
No, you are not.
Can you hear me okay?
Fully. I mean, you are in between, cutting off in between, Chetanji.
Okay. 1 second, sir.
Yeah. Try now.
Yes, you can go ahead with your question. Yes. Hello. Hello, Chetan sir. Hello. Yes.
Yeah, I'm here. Can you hear me?
Yeah,
yes,
yeah, we can hear you, sir. Please go ahead.
Oh, yeah, I'm here. Can you hear me?
Yes,
okay.
sir.
So sorry about this. I think I just have some interruption with my connection. So, Dr. Praveen, my father went through a second replacement surgery. The first one went well. He was able to recover over a period of 3 months. And after which he started using a single arm hand rest like a crutch to walk. Okay. But later, after 3 more months later, when he started moving a little bit more and trying to do physiotherapy, so happened that he completely became bedridden because his infection in his body kind of increased to a level where CRP and ESR was really high. And the doctor suggested that he goes on antibiotics with steroid being one of the components for his quick healing of infection. But then he took these injections, I think steroid injections for a period of 2 weeks, every day 3 of them. But even in spite of which his infection level couldn't go down.
Which
and
is,
unfortunately,
are we
he had to
talking
go through
about
a
the
second
hip?
surgery as well.
Are we talking about
no, the knee.
the knee?
on the knee, osteoarthritis.
He has had a knee replacement in the past, and this has been revised again. Is that what you are saying?
Yes, that's correct.
And you are telling me that after the revision surgery, he is having an infection.
Correct.
And you see, what is his age?
67.
67. Okay. See, if you need to meet your surgeon, okay, and just discuss with them what are the options for infection. If there is infection in the knee, okay, so that infection in the knee needs to get out. However much of, if it is a confirmed infection, if you give only medication, it is unlikely to heal. It might require clearing up operation. Sometimes, if the clearing up operation is also not working, in some cases, it might be better that you discuss with your surgeon about taking out all the implants out and fusing the knee. If you fuse the knee, if all the implants and all get out and they get antibiotics, they might be able to avoid the sepsis. Okay. So, I mean, you have to basically see your surgeon in whichever place you are there and meet them and discuss the options.
Sure, Dr. Praveen. Thank you. I have discussed this option with the surgeon. What I was suggested is to take off the implant, leave it for a period of 6 months, 6 weeks to 3 months.
Yeah, that's
and depending on the infection level in the body, okay, that they're going to place a spacer in between the knee till the healing process is completed. And once they feel that an infection has gone down completely, is where they might go for a third knee replacement surgery with new implants. So do you think that is suggestible? That's advisable?
Well, if you want to retain movement in your knee, okay, it's called as a staged revision. Okay, so stage 2, it is done in 2 stages. That's the gold standard. I mean, you take everything out, put a cement spacer, antibiotic cement spacer, give them antibiotics for 6 weeks. After 6 weeks, you take out everything, go in again, and then do a revision knee, and then continue to give them infection. But if the infection can and it is likely to cure in 80% of the time. But 20% of the time, if the infection comes back again, you have to do what I told you earlier, fusion of the joint.
Fusion of the
don't want to do multiple procedures, or the patient is unfit to have multiple procedures, you can as well go ahead with the fusion surgery. It will avoid bending of the knee, but it will straighten out the knee and they can walk on it and they will have no infection.
Just to ask one last thing, sorry that everybody's waiting to ask questions. Do you think psoriasis could be a cause of infection?
Psoriasis is a higher risk factor for infection.
Oh, is it? Okay, because my dad was suffering with psoriasis for almost close to 3 years, but before the surgery,
see, there are it's a inflammatory joint diseases. You know, the skin condition. There are other post factors inside. Why it's a pro-inflammatory state in the body. Okay, and then he has had one surgery, a second surgery. So I mean, you have to speak to your rheumatologist as well, and I think and your surgeon. Okay, and then they will guide you better regarding this specific problem. Okay.
Sure. Thank you, doctor.
Thank you very much. Keeping in mind the doctor's busy schedule, I think we come to the conclusion. Thank you, sir, for your detailed explanation about prevention and treatment of osteoporosis and osteoarthritis. And on behalf of Vayomanasa Sanjeevani and the other participants of the webinar, we thank you for your valuable time and your input, sir. And those are many questions are there in the offering, so they can email us and they can get back to you, sir. Thanks a lot.
Okay. Thank you very much. Thank you very much. Okay.
Thank you, everybody. I would like to thank Dr. Praveen, sir, for this wonderful session. I hope we are having a lot of questions. Still, the participants are having a lot of questions. You can email us on vms.nimhans@gmail.com. I can directly forward it to sir and get your answer done.
No, I mean, if you have time, if they have any questions, it is because I do not find much time for emailing, so that about that. But if there are people, I am ready to take their questions now.
Yeah? Sure. Anybody else would like to ask any questions? Any participants? Okay. So I think we can wind it up then, sir. Okay, then thank you so much, all the Zoom and the YouTube participants who have joined for today's session, and Dr. Praveen sir for coming for today's session, and Shakuntala ma'am for moderating. And then also at the end, I would like to thank all our partners, Karnataka, Government of Karnataka, then Samadhana Counseling Center, Karnataka State Legal Authority, Bangalore Apartment Federation, Icon Life Science, REC Foundation, NSC Foundation, and Indian Psychiatric Society, Karnataka Chapter 1. With that, we are winding up today's session. Have a wonderful evening. Thank you.
Thank you very much.
Thank you all.